Overnight call as a junior resident for internal medicine. 5 p.m. I enter my call room. The bedsheets have not been changed since the night before. The room is frigid, and the pillow is thin as paper. 6:30. I am called to the emergency department for a hospital admission. Sepsis. Unknown source of infection. I examine a sacral ulcer full of fecal matter. I am gagging. 7:45. I am paged. A family is requesting a medical update about a patient I have never heard of in my life. 8:15. I am called to the ED. A psychiatry patient is returning after being discharged yesterday, but they have a sodium of 130. Admit to medicine. 9:30 p.m. I go to the cafeteria for dinner. The only place open has stale pastries from the day that didn't sell. I almost break my teeth as I bite into them. 10:15. My patient from earlier with the sacral wound is tanking. His blood pressure is in the low 70s. I've given 5 liters of fluids. I call critical care for support. They ask if I've considered giving more fluids. 11. New consultation from the ED. It's a non-operable hip fracture, admitting for physio. 12 a.m. New admission from the ED. The patient cannot urinate and has a history of obstructive uropathy. The urology resident tells me that the patient would be better served under internal medicine as they have many comorbidities. Their comorbidities are high blood pressure, for which they take 1 pill once daily. 2 a.m. I am wrapped like a cocoon with 3 blankets just to keep warm. I'm finally falling asleep. The senior resident calls me. We have another admission. I am banging my head against the wall. I am lying in bed and I am paged to put in a physiotherapy referral. It is 4:30 a.m. 6 a.m. I am paged. Potassium is 5.3 on morning lab work. I review my 100 admission orders I entered for the night. The pharmacy calls me and asks if I intended to order levothyroxine as a PRN. 8 a.m. At handover, the attending reminds me of everything I forgot to do for each case. We go over the hyponatremia workup for 30 minutes. 9:30. I am leaving the hospital. I am paged. A day on the wards as an internal medicine resident. 8 a.m. Our medical students are on vacation. One of our residents is post-call. The team is me, the senior, and the staff. I need to round on 10 patients and discharge 4 of them. The senior tells me I should hold their pager because it's good practice. 8:30. Our patient on high-flow oxygen is requesting a leave of absence to check on their cats. 8:45. I consult a specialist for one of my patients. They ask me 100 questions that I don't know the answer to, then turn the consult down and say my staff can call them back. 9:15. The husband of our other discharge is furious that they are leaving the hospital. They are waiting outside the team room to speak with me. 9:40. The patient asking for the leave of absence just cussed out the entire nursing station and left against medical advice. 5 discharges. 10. Our other discharge asks me to redo their prescription so that acetaminophen is ordered as 1 tablet of 975 milligrams instead of 2 tablets of 500 milligrams. 10:30. The charge nurse asks me why we haven't discharged anyone yet. 11. My senior texts me and asks how many of my ward patients I have seen so far. I have seen 0. 12. There is free lunch today. By the time I get there, everything is taken. 12:30. One of my patients is going into supraventricular tachycardia. Their heart rate is in the 200s. Metoprolol is not touching them. 1 p.m. I am paged. A patient has finished their meal tray and is requesting additional cheddar cubes from the kitchen. 1:15. I am paged. My patient with SVT is going to the critical care unit. 2 p.m. One of my patients asks me about their new multiple myeloma diagnosis. The discussion goes on for 25 minutes. At the end, they ask if they can speak with the real doctor. My staff has a meeting until 3:30 p.m., so we are rounding late today. 3:30 arrives. I have no idea what to do for any of my ward patients. I start panic sifting through their charts. We start rounds at 4. I'm stumbling through as all my patients blend into one. Somehow, I avoid evisceration. 6 p.m. I'm leaving the hospital. Now I just need to write 10 notes when I get home. Overnight call in the intensive care unit as a junior resident in internal medicine. 5 p.m. I am asked to stitch a chest tube site closed. I have not held a suture in over a year. My patient is awake and watches as my hands are trembling over them. 6:15. I'm putting in my first central line in the right internal jugular vein. I can't find the needle tip on ultrasound. I break my sterile field. I almost have a vasovagal and faint. I almost lose the guide wire in the vein. After 45 minutes, it's in. 7 p.m. They tell me I have to fill out a death summary again because I didn't press hard enough with the pen, so it's not legible on the pink copy paper at the back. 7:30. An emergency physician intubates a patient and then refers to the ICU. They tell us the clinical course was heading in that trajectory, so they acted accordingly. We extubate, then we refer to medicine. 9:15. I put in a radial arterial line. I'm staring at the ultrasound screen, so I don't notice that I'm in the artery. I spray my fellow's Patagonia sweater with blood, and then I move the needle out of the artery without noticing. 10:30. I run to a code blue and I request to only do compressions. 11:45. Medicine gives us a consult. The patient has left-sided parotitis so bad it looks like there's an apple in his face. Also, he has sepsis. Also, he has renal failure. Also, he has liver failure. We get an ECG and it's the first time I am seeing a STEMI in my life. I call cardiology and they tell me it's a demand STEMI. Soon after my fellow goes to sleep, the anesthesiologist calls and gives us an admission. They say extubation after the OR was impossible because the PaO2 was not high enough. I guess I take their word for it. The charge nurse asks me if I'm seriously accepting this patient from anesthesia. I explain to them that I'm 6 months into residency, and my pushback is equivalent to a mouse nibbling at the toes of a giant. We tell nephrology to keep giving midodrine to their dialysis patients so we don't have to admit them. New admission. A patient overdosed in the emergency bathroom on drugs we didn't give him. Someone on blood thinners decided to become a motorcyclist and now has a brain bleed. Rounds begin. I'm talking too long and no one is listening. The surgical resident is rolling their eyes at me. Rounds finish. I missed a page. They called my staff about potassium replacement at 5 a.m. What I eat on overnight call as a junior resident in internal medicine. If I don't meal prep, I gain weight. So it's day 5 of Fish Week. I proportion my servings according to the Mediterranean diet. 1/4 lean protein, half vegetables, 1/4 whole wheat carbohydrates. I cook with avocado oil to lower my LDL cholesterol. At the hospital, I look for a microwave to heat my food, and why is it so relatable? My lunch from yesterday is not sitting well, so I go to the cafeteria to look for something to settle my stomach. The cookie contains 34 grams of sugar, so I still have a chance at staying beneath the American Heart Association recommended daily limit of sugar intake, which is 36 grams. I managed to find beef jerky with actual beef in it. Later on, I need a pick-me-up, so I make myself a mocktail with a 0 sugar ginger ale. Add 1 cup of either apple or cranberry juice, and then a splash of orange. A nurse walks in and asks what I am doing in the nutrition room. I tell them I'm preparing it for a patient. I'm hungry again, but if I get Uber Eats delivery, I'll lose 30% of my call stipend. So I opt for an emergency department tuna sandwich from their fridge. Someone left a year-old bag of microwavable popcorn in my call room drawer, enough to nourish myself through the night. I get back home, ready to have an actual meal. And it's day 6 of Fish Week. Overnight call as a radiology resident doctor. CT abdomen ordered. Rule out appendicitis. The patient had their appendix removed 4 years ago. An 83-year-old woman needs brain imaging to rule out a stroke. She is too agitated, so she is given 10 milligrams haloperidol and 4 milligrams lorazepam before her CT scan. No stroke. Her care team is then worried that she is too drowsy. A second CT head is ordered. Still no stroke. Internal medicine requests a STAT-CT pulmonary angiogram to rule out blood clots in the lung. You ask them which clinical features support their diagnosis. They tell you they just can't figure out what's going on. Your last year was all off-service rotations. You didn't work with any service long enough to become strong clinically. You also forgot all of your radiology knowledge. The elective medical student is starting to show you up. A patient falls from standing height. CT head, neck, thorax, abdomen, and pelvis requested to assess for injuries. Their ankle fracture is missed. A frequent visitor of the emergency department has a habit of falling on top of cylindrical objects. The order request on the next CT abdomen and pelvis simply says, assess. The general surgery resident says you are the one full of shit for your obstruction call on your CT abdomen from 3 hours ago. You are called 5 times to fit in an urgent MRI. The patient arrives delirious and you are asked to supervise. They can't stop shaking and you forgot what patients look like in color. The scan is non-diagnostic. Internal medicine orders an X-ray in order to rule out constipation. 5 STAT CT head scans arrive in your inbox at once. As you keep finding incidental nodules, you wonder if the department will offer compensation for all the follow-up ultrasounds you have recommended. A cancer screening CT pan scan is ordered STAT overnight. You start praying someone will throw a wrench at the scanner and break it. You don't really know what's happening in the next scan. There is no previous report for you to copy its findings. You try copy-pasting a screenshot into Google image search to help. After changing your report 10 times overnight, your colitis diagnosis becomes benign in the morning when the staff reviews. You are copied on an email regarding a report you wrote last week. A patient is upset you called them unremarkable. You are walking home. You receive an email reminder for slides to read before your quiz tomorrow. A day in clinic as a family medicine resident doctor. You are back from your week off. You have 80 messages in your inbox. The clinic is overbooked, so you have to see a patient every 10 minutes. You wonder if you should have left for vacation in the first place. Your patient wants to start Ozempic, but only for the summer because he prefers to dirty bulk in the winter. He qualifies for coverage with his insurance. He tells you he's going to Dairy Queen to celebrate. Your next patient requests daily low-dose ivermectin for breast cancer prevention. You are sent a discharge summary from the emergency department for one of your patients. Chest pain, heart attack less likely. Please follow up on outpatient troponin and CK to confirm. Your next patient printed a list for their issues. As you finish tackling the 6th issue and head for the door, they tell you they also have chest pain. 6-month follow-up for lifestyle changes. Your patient tells you they've stopped eating Domino's for weeks. They just switched to Pizza Hut. Ivermectin guy is still here. He is refusing to leave your office. He is requesting a breast exam. He is willing to compromise and accept a prophylactic fenbendazole prescription. You take a developmental history for your new pediatric patient. Their mother tells you her son's dad's dad is brothers with her mom. Another discharge summary from the hospital. Please titrate antipsychotics for this 54-year-old male with schizoaffective and generalized anxiety disorder. Monitor for metabolic side effects with consideration for his type 2 diabetes, chronic kidney disease, coronary artery disease, and congestive heart failure. Psychiatry referral pending between 12 to 18 months. A patient asks if you have expertise in pelvic massage and foot reflexology for arthritis relief. You politely tell them no. You turn your computer screen away to look up a medical question during the interview. Google tells you to ask your family doctor, but you are the family doctor. A specialist has requested you order an EEG. They deferred reporting the driver's license for possible seizures to the capable family physician. You carefully explain to the patient how this lies within your professional duties. You were prepared for a crash out, but this one surpasses even your wildest imagination. You have the choice of eating lunch or finishing notes to leave on time. A day in clinic as a family medicine resident doctor, Part 2. Your patient lost the bottle with the small blue pill and stopped taking it for 2 weeks. You're not sure if they are referring to their warfarin for stroke prevention or their Viagra. Hemoglobin lab result back at 60. You are frantically calling your patient to go to the ER. They are on the beach. They say they appreciate your phone call and will get on it when they're back from vacation. A patient asks why their monthly gut health microbiome scores drop whenever Mercury is in retrograde. They ask if you could smell a sample to check. You are told their pituitary gland feels off. Please test it. One of your patients is coming every 3 weeks for earwax cleaning. You don't understand how he is building up this much this quickly. It might be case report worthy. You are asked for a letter approving indefinite time off work for a patient due to impaired typing from a wrist sprain. You are calling a patient from a blocked number. He asks if you are his second girlfriend. This is after you have already started speaking. They were walking in the area and just wanted to come say hello. They're hoping you can fit them in. They also have a nail through their foot. You send them to emergency. They did some Googling and they are convinced they either have Parkinson's, mercury poisoning, or hepatitis. Your orthopedics referral is rejected. They need MRI first. Wait time is 8 months for the MRI and 12 months for the ortho consult. They have a tingle in their left ear on the 5th and 17th days of every month, which lasts for 20 minutes and then goes away. You brainstorm your workup. Your patient has been trying to get into your clinic for 2 months. They accuse you of ghosting. Your patient is concerned about mild shortness of breath with running. You explain that you have moderate shortness of breath with running. You told your patient she has anxiety. After some abnormal blood work, you sent her to a rheumatologist. She actually has vasculitis. They have 5 forms for you to fill out. The 5th form is a birthday card for their nephew. They ask you to sign it. You go home. You have 10 notes to write, 9 labs to review, 8 prescription refills to send, 7 consultation letters to read, 6 EPAs to send, 5 emails to reply to, and 4 dungeons with your Warcraft guild. Overnight call as a psychiatry resident doctor. You have tried talking to your patient for 3 days. Her psychiatric hold is expiring soon. Every time she awakens, there's a crash out requiring sedation. You get a couple words in. She throws her meal tray across the room and the lorazepam is ordered. You are tidying up the dog history in your admission note, but you can't remember if their Doberman was named Ruffles or Rufferson. 2 patients with bipolar are trying to hook up on the couch. You're not sure what to do, so you call Code White. You talk to the male patient with bipolar and he says the girl is coming on to him, but he sees her more as a friend. Your patient has stomach pain, but you forgot how to perform an abdominal exam. A man tells you ghosts are assaulting him, requests for a room without ghosts. You run it by your charge nurse. Your patient informs you that her husband has been crushing her medications and hiding it in her cocaine. She hands you a bag and asks you to fish out the meds. You tell her this is just cocaine. A 29-year-old male appears drowsy. His home medications include clonazepam, lorazepam, trazodone, gabapentin, quetiapine, and haloperidol. Where do you start? Your patient says that they have seen you walking at an intersection near your house. You are asked to read an ECG. You are in shock. The emergency department hands you a form for a psychiatric hold. The patient is depressed about sold-out Labobos and seeks retribution. It's labeled as potential for harm to self and others. You remember to remove yours from your waist belt before you start the interview. Your patient feels that you are a part of the system profiting off him. You tell him your profits are a $75 stipend for the night. He stands up suddenly. You left your beeper in the other room. You hand the psychiatric hold form to your patient and they fold it into a paper airplane and throw it back at you. You try calling a husband for collateral, but he is harder to understand than the patient. Your next patient is explaining how he has been selected to be caretaker of the Overlook Hotel. You slowly realize his history of presenting illness is the plot summary for Stephen King's The Shining. You are going to sleep. Overnight call as an anesthesia resident doctor. Orthopedics is requesting a consult for pre-op optimization. The patient only has pre-diabetes. You ask your staff if it's necessary to see the consult. They say just go lay eyes. Leave a quick note while you're at it. And also grab the sticker. After a slow induction and even slower room turnover, your staff says their 11-year-old daughter could do this next intubation. You intubate the esophagus. The surgeon starts cussing you out. Your staff tries to defend you out of pity. Your staff also gets cussed out. You notice your patient's teeth are chipped on extubation. They're Canadian though. They probably played hockey at some point. You fish zins out of your patient's gums in the operating room. To be fair, the instructions were only you can't eat or drink anything. Everyone is staring as you try to get an arterial line in an anticoagulated patient. You blow the line and their arm balloons. Your hip replacement case is going slow. There's nothing to do except for the staff to pimp you. They ask what your anesthetic plan would be for an LVAD patient coming in for emergent craniotomy. You've spoken to a patient for 6 minutes. It's a new record. You don't really want to entertain the conversation any further. You put them to sleep. You are called to an urgent intubation for a pre-arrest. Short neck, OSA, high BMI, thick beard. The surgeon says the patient is not paralyzed. You look at the nerve monitor and it shows 0 twitches. You push normal saline and tell them the patient is now re-paralyzed. Fourth code blue of the night. It's the psych ward. It's the same guy hitting the alarm in the bathroom. You ask him to stop and he just tells you to sug him a dex. You have 3 pending consults, 2 pain service pages, you have to pick up your staff's coffee, but the med student is closing skin. You tell your staff you're worried that the heart rate is 43, but they're only worried until the heart rate is 39. The surgery resident tells you to raise the bed and then lower the bed. It ends up being in the same position. There is a code blue in the same obstetrics room where you gave an epidural for a patient in labor. Your heart sinks. You walk in and the husband fainted. You hand him some juice. Your patient won't fall asleep under sedation. You start telling them about the mechanism of anesthetic vaporizers and that does the trick. The surgeon has been playing American death metal band Dying Fetus for the last 4 hours. You debate self-injecting midazolam. You settle for just sneaking earbuds in for some kind of noise suppression. You are going home. You left your pager in your front pocket. It's a stat page from acute pain service. You forgot to order Tylenol.